Welcome to CANVax's webinar series. Between fall 2019 and winter 2020, CANVax is hosting a series of webinars that explore current and emerging topics in immunization. Our purpose of hosting these webinars is to support and inform the work of public health professionals to improve vaccine acceptance and uptake. To learn more about our upcoming webinars, please visit our website at canvax.ca/canvax-webinar-series, as you see indicated on the screen below. Before we begin, we would like to acknowledge that CPHA's office is situated on the ancestral and unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and CPHA is grateful for the example their stewardship provides. CPHA is committed to working with all First Nations, Inuit, and Métis peoples and their government in realizing meaningful truth and reconciliation. Today's webinar, Managing Patients with Adverse Events Following Immunization, is brought to you by the Canadian Public Health Association through the CANVax project and its partners, Immunize Canada, the IWK Health Centre, and the Institut National de Santé Publique du Québec. I'm Antonella Pucci, CANVax Project Officer with CPHA, and I'll be the moderator for this webinar. Before we begin, there's just a bit of housekeeping that should be noted. We are using the Zoom platform for our webinars, and all attendees on Zoom are muted. However, the toolbar located at the bottom of your screen offers you a few interactive features. For this webinar, the Q&A feature will be used to pose questions. If you have any questions, please post them in the Q&A box. Only you, myself, and the presenter can see your questions in the My Questions section, and you, as the attendee, have the option to submit them anonymously. When asking a question to the presenter, the question is first read out loud, answered live by the presenter, and then posted in the All Questions section. If you have any questions regarding technical difficulties, please also ask them in the Q&A box, and we will reply to you. If multiple people are experiencing the same problem, we'll address it live. But we strongly encourage attendee participation and look forward to hearing your thoughts and questions. I'll be moderating these questions, so feel free to submit your questions at any point during the presentation by using the Q&A feature. All questions will be answered in sequence at the end of the presentation. Finally, there are some quick notes before we start. Our webinar is being recorded and will be made available on canvax.ca and on CPHA's YouTube channel shortly after this presentation. Please note that after the end of the webinar, you'll be invited to take a short 5-minute survey. We strongly encourage that you take this survey to provide your feedback so that we can assess your satisfaction and identify areas for improvement in the delivery of these webinar series. Further, if you haven't already registered with CANVax or subscribed to our newsletter, visit canvax.ca today to do so. So with that, let's begin. I would love to introduce our speaker for today's webinar, Dr. Karina Top. Dr. Top is a pediatric infectious disease specialist and clinician scientist in vaccinology. She is an associate professor of pediatrics and community health and epidemiology at Dalhousie University in Halifax, Nova Scotia, and an investigator at the Canadian Centre for Vaccinology. She completed medical school and pediatric residency at Dalhousie University, followed by fellowship training in pediatric infectious diseases and a Master of Science in Epidemiology at Columbia University. Dr. Top is the principal investigator at the Canadian Immunization Research Network's Special Immunization Clinic Network, which aims to standardize and improve the management of patients with adverse events following immunization. She is also an investigator in the Canadian Immunization Monitoring Program, ACTIV. Her research focuses on vaccine safety and surveillance, management of patients with previous adverse events following immunization, vaccine safety in pregnancy, and the evaluation of vaccine safety and effectiveness in immunocompromised patients. So with that, I would like to turn it over to Karina Top to start sharing your slides.
Great, well, thanks very much, Antonia, for the nice introduction, and thanks for the opportunity and the invitation to share our work with you and with the CANVax community. So as was mentioned, I run the Special Immunization Clinic Network, and one of our main focuses is to evaluate and help improve the managing patients who've had adverse events following immunization. So I'm pleased to share some of our work with you, as well as guidance that we've developed to help public health professionals and healthcare providers in assessing and managing these patients. So first, in terms of disclosures, I've received grants from GSK to my institution and consultancy fees from Pfizer to my academic account for vaccine studies unrelated to this work. So for the objectives of my presentation, I hope that by the end you'll be able to incorporate best practices for adverse event following immunization, or AEFI management, into your work, to assess some AEFI scenarios and plan a course of action for reporting and management, and assess and access evidence-based resources for managing patients who have more complex or clinically challenging AEFIs. So I thought we could start with a case, which is probably something many of you have encountered before in your work. So an 18-month-old boy who was previously healthy, fully immunized, and presented for his routine well-child visit with his family physician, and was given his 4th dose of diphtheria, tetanus, pertussis, polio, and Haemophilus influenza type B booster in his left deltoid. And then a few minutes later, they started to notice development of erythema and swelling of his arm around the injection site that eventually ended up extending from shoulder to elbow, as shown in the picture here. Obviously, this is a little bit older. Around 90 minutes after vaccination, he also spiked a fever to 102 Fahrenheit. And so this was a case that did end up getting reported. But if you encounter a case like this, you may be asking yourself, probably consider a number of questions. So first of all, what is this? What's the diagnosis or your assessment? What would be your immediate management of this type of adverse event? Is it reportable? Does it need to be reported to public health as an AEFI? And what are you going to tell the family about the next vaccine? So his 4 to 6 year booster of DTaP. So I'll let you ponder those, and we'll come back to that a bit later in the presentation. So we do know that AEFIs do occur. We counsel families that children can experience fever and pain, sometimes irritability or fussiness after vaccination. But when these events are more severe and come to medical attention, they may cause concern among patients and their healthcare providers about the safety of continuing with future vaccinations and the risk of such an event occurring with the next vaccine. We do know that even common expected AEFIs can contribute to vaccine hesitancy among patients and families, and raise concerns around the safety of vaccines. So we also know that often in these cases the precautionary principle will win out if clinicians are uncertain about the evidence or the safety regarding future vaccinations. So without clear evidence-based guidance, they may opt to withhold vaccines from these patients, and that may put them at risk of vaccine-preventable disease in the future. So to address knowledge gaps around AEFI recurrence and the safety of continuing with vaccination, we established the Special Immunization Clinic Network within CERN, or the Canadian Immunization Research Network, back in 2013. And the initial objectives of this network were to standardize and improve the clinical care of patients with previous AEFIs, as well as those with underlying medical conditions that could contraindicate vaccination, to gather data on these patients to determine the rate of AEFI recurrence for specific types of AEFIs or associated with specific vaccines, and to develop a research platform for further studies of vaccine safety, adverse events, and vaccination immunocompromised populations. So over the past nearly 7 years now, we've developed a national team of expert clinicians with an interest in vaccine safety and growing expertise in managing patients with AEFIs. Each site is run by a pediatric infectious disease specialist who works in collaboration with adult ID, allergists, clinical immunologists, and other specialists at each site to help manage patients with a range of adverse events. So here you can see the sites that are currently active across Canada. We have 12 sites in 6 provinces. Most are, well, essentially all are based in pediatric tertiary care centers. However, here at the AEFI, we do collaborate with Shelley McNeil, who's an adult infectious disease physician with expertise in vaccines, and I think gave a previous webinar, as well as with our allergy colleagues who, some of whom also see adults. So we do see adults in our clinic. And in Ottawa, they've recently begun a collaboration with physicians at the Ottawa Hospital to see adults with adverse events there as well. So we are trying to build our capacity to see adults, although we primarily are pediatric focused. So how do patients come to our network and to our clinics? Well, they do require referral by a healthcare provider, and we'll accept referrals from public health care providers, public health nurses, although generally do need a physician name in order to be able to bill. The visits are billed as part of routine clinical care, so it's a clinic assessment. And then we'll see all patients that are referred to the network, but there are certain inclusion criteria to be considered part of our SIC Network study. And these are patients with more severe adverse events that where there is a greater concern around the risk of adverse event recurrence or implications with future vaccination. And so these include events such as large injection site reactions that are greater than 10 centimeters in diameter, allergic symptoms within 24 hours after vaccination, so that could be hives, angioedema, anaphylaxis, high fevers, hypotonic, hyperresponsive episode or persistent crying after vaccination, neurologic symptoms, really any neurologic symptoms after vaccination, and other AEFIs are conditions of concern where the investigator at the site thinks that it would be of interest to the network to collect data. So there is some leeway offered to investigators. And this gives us the potential to be able to evaluate and investigate new safety signals as well should the need arise. So some of our clinics also see patients that have concerns about vaccines that are just generally vaccine hesitant, for example, but we wouldn't include those in our database. So patients with previous adverse events will undergo a standardized assessment. We collect as much data as we can ahead of time and during the appointment on exactly what happened with the adverse event, details of the vaccination associated with the adverse event, and then we'll conduct a causality assessment. So it's an informal causality assessment really, but involves uses the World Health Organization's algorithm to assess the association between the vaccine and the adverse event. Physicians also do a risk-benefit analysis and then use all of that information in discussion with the patient to make a recommendation around revaccination. And we do have network protocols that have been actually adapted into a resource for public health, and I'm going to discuss that in a little bit. And so all of that goes into making evidence-based recommendations for revaccination. And then where possible, patients are revaccinated in the Special Immunization Clinic, and then they're all followed up post-vaccination. But if patients prefer to go to their family physician or they're not yet due for the next dose, then our SIC nurses will follow them up and capture all the details of the vaccination and whether any adverse event occurred following revaccination. And all of this information is then collected on a standard data collection form and entered into our national database as denominalized data with individual participant consent. So between 2013 and fall of 2019, we had received well over 1,000 referrals to the network. And among those, we enrolled 636 patients with previous AEFIs. We have about 50% male to female distribution, and about 90% of our participants are children under 18 years of age. As I mentioned, the clinics are across 6 provinces, and most of the patients come from Eastern and Central Canada, so Ontario, Quebec, and Nova Scotia. So what types of adverse events do we see? We really see a very broad range of AEFIs. Most common would be allergic-like events, over 230 in the database. Most commonly hives, but we have had quite a number of cases of anaphylaxis, as well as patients who've had some more delayed onset hypersensitivity reactions, like serum sickness-like reactions, for example. Injection site reactions would be the next big group, and over 150 injection site reactions. Most are extensive limb swelling or large local reactions with greater than 10 centimeters of swelling or erythema. With neurologic adverse events, the most common we would see are seizures, but we also have a number of cases of Guillain-Barré Syndrome, transverse myelitis, paresthesias, really a full range. And then for the other systemic AEFIs is another big category. Common among those would be fever, as well as hypotonic hyperresponsive episode, HHE, and persistent crying, as well as nonspecific severe systemic symptoms like gastroenteritis or gastrointestinal symptoms, for example. This is quite a busy slide, but just to show that we really do see adverse AEFI type, all AEFI types associated with any with all types of vaccines. So most commonly, we see AEFIs after the diphtheria, tetanus, pertussis vaccines, which is not surprising given that we need to give so many doses of those vaccines compared to other vaccines like MMR. We also see a lot of large local reactions with influenza vaccines, and in particular recurrent large local reactions year after year. But overall, there's really no other clear patterns between the vaccines and the particular types of adverse events. And I should note that most patients that we see have had more than one vaccine prior to the onset of their symptoms. And so, again, it's often difficult to sort out which vaccine caused the particular adverse event. So this is just to show that most of the AEFIs we see are of low to moderate severity or impact, and we measure the impact of the AEFI really on daily function and need for medical attention using the criteria that's in the Public Health Agency's AEFI reporting form, the National AEFI reporting form. So low impact would be events that can be managed without medical attention or just at the vaccine clinic, or result in less than 24 hours of disability. Moderate would include an emergency department visit, and then with recovery within a few days. High impact are those that require multiple physician visits, or up to 2 weeks of disability. And then serious are, by the SILAM's definition, requiring hospitalization or resulting in permanent disability, are life-threatening, for example. So, most of the events we're seeing, as you can see here, are low to moderate severity, but the neurologic events do tend to be the ones that are the most severe and serious. So following the SIC assessment, this shows the proportion of participants whose physician recommends revaccination, and you can see that across all AEFI types, the majority of participants will receive a recommendation to continue with vaccination. So up to 85–95% of those with allergic events and injection site reactions are recommended to continue on with vaccination. It's a little bit lower for neurologic events where they're more likely to be advised against immunization. And again, likely reflects the severity of those types of events as well as uncertainty around the role of the vaccine in many of those types of events. And we'll discuss a case in a little bit that will illustrate that a little bit better. So once participants have gotten a recommendation to be revaccinated, then we also capture what their plans are. Do they intend to get revaccinated or not? And again, the majority of participants who are advised that they can continue with revaccination will plan to get revaccinated. Many of those are revaccinated in the SIC, but as I mentioned, some of them may be revaccinated at a later time. So particularly for allergic-like events, it's often built into part of the assessment that the allergist will do skin testing. If that's fine, then they go ahead at the same visit and give the vaccine. You know, again, similar to the physician recommendations with neurologic events, we do see a bit more a higher proportion of participants who are do not plan to continue with vaccination or maybe a bit more concerned about the safety of proceeding with vaccination. Overall, though, my experience certainly is that these families are highly motivated to continue vaccination, or else they probably wouldn't have come to our clinic for assessment in the first place. So we're generally dealing with a very pro-vaccine group. Even those, I see lots of kids who've had recurrent large local reactions with flu vaccine, and you know, the parents and often the child as well are keen to just keep going and plow through, which even though unfortunately we don't have a whole lot to offer them to reduce the risk of recurrence, particularly without availability of live attenuated flu vaccine. So among those who intend to be revaccinated, then we have seen a bit of a drop off between those who say that they do want to get revaccinated and those who actually do get revaccinated, or for whom we are able to get follow-up data on revaccination and outcomes after revaccination. So in total, we've revaccinated well over 300 people at this point, and we're working on trying to get more complete outcome data on these patients. But overall, so far the data that we have is reassuring in that the risk of recurrence is overall is below, it was just about 10%, and it's mostly driven by injection site reactions, where we have seen about 24% risk of recurrence of those types of reactions, but much lower for other types of adverse events, including allergic events. And these are the ones that clinicians are often most worried about in terms of the risk of, that there'll be a risk of a more severe allergic event with the next vaccination. And we really see very few instances where the adverse event recurs. And here lower in the table, we captured how severe the event was relative to the initial adverse event. And again, most of these recurrences were milder than the initial adverse event. And there was only one case of allergic event that was more severe than the first event. Some of the other systemic events were similar severity. So again, most patients can be reassured that the risk of recurrence is low, and most recurrences will certainly not be any worse than the first event, and most will be likely less severe. Reassuringly as well, we have not had any serious adverse events as a result of revaccination, and over 6.5 years of the SIC. So let's go back to the case and discuss sort of more specifics about what we would do in some of these cases. So if you're thinking, seeing a patient like this, which I'm sure many of you working in public health have had calls like this or seen these types of cases. So first off, what's the diagnosis? So this would be meet criteria for what's referred to as extensive limb swelling, where you have erythema and swelling that either extends from joint to joint or crosses a joint, which you can see in the photo here, does seem to cross over the shoulder and down almost to the elbow. So it's usually, and it's an impressive reaction, but it's usually associated only with mild pain and discomfort. And this is a different child who I saw a number of years ago with a reaction after flu vaccine, and really had no pain with moving his arm all around, but did have marked swelling without induration. And I got called to see him in the emergency department because they were wanting to start antibiotics on him. But fortunately, we were able to head that off. So generally, they are non-toxic. They don't have systemic inflammation. As I mentioned, the case that this particular case of the 18-month-old did have fever, but often they don't. And these reactions are self-limited. They resolve without any scarring or other sequelae, and they're a pain and can be uncomfortable at the time, but not dangerous. And so our recommendations in the SIC network have been to continue on with immunization. Unfortunately, we don't have any evidence to show that you can prevent these types of reactions, except that we do suggest using the lower antigen formulation of Tdap, which I'll discuss in a moment. Other types of injection site reactions to consider are cellulitis. So is it a bacterial infection or a bacterial abscess? I mean, these are extremely rare and really suggest some immunization error. So a break in aseptic technique or contamination of the vaccine vial with bacteria that got inoculated into the skin and caused infection, and are very rare in a setting such as ours. And certainly that's not something that should recur with the subsequent immunization. However, large injection site reactions and extensive limb swelling can often be misdiagnosed as cellulitis and treated with antibiotics unnecessarily. The other type of injection site reaction we consider are arthus reactions. So this is basically a vasculitis type reaction where you have antigen antibody complexes deposited in the skin, and that can cause some scarring, and it is recommended to consider extending the interval between vaccinations. It's mostly been associated with tetanus-containing vaccines, and so they would suggest not to give another tetanus booster within 10 years. But of course, that would depend on risk-benefit assessment. But those are fortunately rare in children. So in this case, we advise just simply symptomatic management with antipyretics, acetaminophen, ibuprofen, and you can consider second-generation antihistamines like cetirizine to relieve the swelling if there's more swelling and pain. Most of these types of events would, again, you should check with your province or territory, but would generally not be reportable. But if it's a patient that ends up in the emergency department and getting IV antibiotics, and that, it's probably worth reporting to track those types of events. And we certainly are happy to see these patients, particularly when they have multiple recurrences of large local reactions. So in this case, we would recommend continuing with immunization, and for the preschool booster to make sure to give the Tdap IPV, so the reduced antigen formulation of tetanus, diphtheria, pertussis, rather than the capital DT, a capital P. And this lower antigen formulation is associated with lower risk of recurrence of large local reactions for the 5th Tdap dose. But you do need to counsel these families that the risk of recurrence is fairly high, 25 to 50%. But as I showed you earlier, that they tend to be less severe than the initial event. So move on to another case. So this is a 5-year-old boy, and these are real cases that we saw in the SIC clinic. 5-year-old boy got his first dose of trivalent influenza vaccine and is left deltoid in his family physician's office. 5 minutes later, he complained that his mouth felt funny and he gagged and went limp and pale and was unable to stand up. So they administered epinephrine right away, IM, and called emergency health services, who came to the clinic, arriving about 15 minutes later, or 20 minutes post-vaccination. By then, the child was improving, was responsive again. Vital signs were normal at that point, not hypotensive. But they decided to bring him to the ED as a precaution. And by the time he was there and settled, he was back to his baseline within an hour. Never noted any hives or skin rash, but there was a question of mild periorbital edema, but no cough or wheeze reported. And in terms of his past medical history, there's no history of ATP, so allergy or asthma, and no problems with any of his previous immunizations or any of his routine childhood vaccinations. So again, you would be faced, if you're getting this call as working in a public health office, or if you're the physician taking care of this child, you would be asked, you may be considering these questions about what's your diagnosis or assessment, do you need to report this to public health, and then we'll talk about what resources are available to help you manage this patient and what to do next. So a key thing with these early vaccine reactions is to differentiate anaphylaxis from other types of early vaccine reactions, particularly immunization stress-related responses. And this is the new term for immunization anxiety reactions. And the WHO has put out a very detailed guideline on how to manage ISRRs. It's I have a link to at the bottom, and there is a summary, a 7-page summary. So there's a lot of information there. But I think what the keys here are, there are some key overlaps, but some key differences as well between anaphylaxis, vasovagal syncope, and other types of stress reactions, which have also been referred to as sympathetic stress reactions. So one key is onset. So with anaphylaxis, you would not expect to see it within 5 minutes of vaccination. And if you think about it, you're injecting, providing the vaccine, and then the vaccine itself has to activate mast cells and induce a type 1 hypersensitivity reaction, allergic reaction. So that takes a few minutes to occur. So generally, you wouldn't see it before 5 minutes after vaccination. For stress reactions, of course, the patient or the client is stressed before the vaccine often. So these can sometimes have onset even before, during, while you're giving the vaccine, or soon after. And in this case, it was right around 5 minutes the child started to feel unwell. So kind of a borderline for either anaphylaxis or syncope. Skin changes, of course, with anaphylaxis, you'll almost always have hives and angioedema, so swelling of the face and eyes, periorbital, and a generalized rash. In contrast, they tend to be pale, sweaty, clammy with stress-related responses. Again, cough, wheeze, stridor should alert you to anaphylaxis, whereas breathing can be normal, deep, or they may have hyperventilation if it's a stress response. Cardiovascular GI, there can be a bit of overlap again, and any of these patients can have certainly syncope or anaphylaxis can have loss of consciousness, but with syncope, of course, once you lie them supine, then they generally will perk up. With sympathetic stress reactions, one of the hallmarks is paresthesias and numbness, right, especially around the lips and face, and they may have spasms of their hands, which is a side effect of the hyperventilation. So what do we do with these types of patients? Well, the biggest concern, of course, the reason for referral was, could this be anaphylaxis? So for allergic-like events, we have actually a detailed algorithm, but simply put, if a patient has anaphylaxis, within 24 hours after vaccination, well, or at any time really, they should be referred to an allergist for skin testing. If it's related, anaphylaxis from a vaccine or vaccine component will almost always present in the first hour or 2 hours post-vaccination. But of course, regardless, you need to figure out what did trigger it, whether it was the vaccine or something else. And we would, of course, hold off on giving any of the same vaccines, or usually any vaccines, until that's been sorted out. And as well, those who have onset of hypersensitivity symptoms, so hives, angioedema, respiratory compromise within an hour after vaccination, also should be referred for assessment. And as with this case, there's that need to differentiate between allergic events and other stress reactions, including HAE in infants. But other patients, so those with later onset of hives a few hours after vaccination, for example, can be safely revaccinated in a usual setting. And of course, any place where you're giving vaccines, you need to be set up to manage anaphylaxis should it occur. But the risk of anaphylaxis in those patients is very, very low. The true contraindication would be if the patient's is found to actually have a demonstrated allergy to a vaccine or a vaccine component, and then they shouldn't receive that vaccine in the future. As well, patients who've had Stevens-Johnson syndrome, toxic epidermal necrolysis, erythema multiforme, and serum sickness-like reactions, those would also be contraindications to further vaccination. But again, referral to a specialist like a special immunization clinic or allergist, immunologist would be helpful to sort that out, those types of reactions. So in this case, the real key was this syncope versus anaphylaxis, and it really did seem like syncope, but one of the challenges was the patient got epinephrine, so how much did that modify their clinical course? So in terms of reporting, I mean, this was reported to public health, and I think should be, because epinephrine was given, so there was concern for a life-threatening event, and it required an emergency department visit. For the next immunization, what we did, he was referred to SIC and on to an allergist who conducted skin prick testing against the vaccine, which was negative, and then he went on to receive TIV the next season without any issue. So the conclusion was that this was most likely vasovagal syncope. And in those cases, some measures to just provide a calm environment, distraction of the child, and making sure that they're seated and supported or vaccinated either lying down or in a seated position with support, and then monitoring them post-vaccination should avoid any further recurrence. And so the final case is a slightly more complicated one of a 13-month-old boy who developed refusal to walk, lower limb pain, and irritability about 2 weeks after receiving his 12-month vaccines, the PCV13, MMRV, and meningococcal C conjugate vaccine. So he was previously healthy, developmentally normal, walked at 11 months of age, and then about 2 weeks after getting his 12-month vaccines, parents report that he became unsteady on his feet and very irritable and refused to be held, which is often a red flag in young children. And these symptoms progressed over the next few weeks to the point that he wasn't able to pull himself to stand and had difficulty sitting independently. At one point, the pediatrician also thought his reflexes were decreased. He initially actually was worked up for possible leukemia with concern that he had bone pain, but that workup was negative, and eventually he was referred to Neurology, who questioned whether he had Guillain-Barré Syndrome. In terms of his clinical course, his symptoms did sort of reach a plateau at this around 3 weeks in, where he, with this difficulty sitting independently and unable to pull to stand, and then gradually over the next 5 weeks, he started to improve and got back to his baseline function. When I saw him about 6 months later, he was running around like a healthy 18, 19-month-old. Also of note that he'd had a history of acute otitis media about 10 days prior to the onset of the refusal to walk, so about 4 days after vaccination. So just for those who are less familiar, Guillain-Barré syndrome is an autoimmune disorder. Peripheral motor and sensory nerves can involve cranial nerves. Most classically causes flaccid weakness of the limbs, so sort of a floppiness, and decreased tendon reflexes. Can also cause severe paresthesias, so numbness and tingling, and sensory nerves. Can affect the diaphragm and ability to breathe, as well as like cough reflexes and whatnot in terms of cranial nerves. And the symptoms gradually progress over hours to a few weeks to reach an onset, a nadir, and then they plateau for a while and will gradually improve. So it results from autoimmune destruction of the myelin sheaths around peripheral nerves, and it takes quite a while for those sheaths to regenerate. But in kids, the outcomes tend to be a bit better. Adults have a reasonably high mortality and can take months to even a year or two to fully recover. The diagnosis is tricky, but is often associated with high protein in the spinal fluid, with normal white blood cells, or with abnormal nerve conduction studies. But unfortunately, in this case, actually none of that was done at the time because it was such a difficult presentation. Some questions. So, certainly neurologists had already thought that this may be Guillain-Barré syndrome, but what, would be the role of the vaccine, and what do we do next? And in terms of the Guillain-Barré syndrome itself, GBS has been associated with certain pandemic influenza vaccines, so in particular the swine flu vaccine in 1976, I think, as well as the 2009 H1N1 pandemic vaccine. There's a very small increased risk of GBS associated with that vaccine in some studies, about 1 per million. But there's also been good evidence to show that the risk of GBS is also increased with influenza infection. So influenza infection can trigger GBS as well as the vaccine, and much more likely to trigger infections, a more common trigger. We've also seen, at least there's one case report of a patient who had recurrent GBS after 3 successive doses of tetanus-containing vaccines, and so that's considered potential risk that either of those vaccines could trigger a recurrence of GBS. So patients that have had GBS with onset within 6 weeks of flu vaccine generally would be contraindicated for further flu vaccines, although again, you need to consider risks and benefits given that we know that the infection can also cause this. Those who've had onset within 6 weeks of a tetanus-containing vaccine, it's suggested to consider risks and benefits. Again, generally probably avoided unless they needed a tetanus vaccine for wound prophylaxis or hadn't completed the primary series. But GBS with onset within 6 weeks of other vaccines can be considered for revaccination. There's limited data, but there's some large cohort studies out of the Vaccine Safety Data Link in the US of well over 500 to 600 patients with GBS that showed no incidence of recurrences after in patients who had been associated with a revaccination. So the risk of recurrence is, if anything, is very, very low. But I also have seizures up there just to highlight some of the other neurologic events. So if you've had a seizure after vaccination, we do recommend these patients can be safely revaccinated. With febrile seizures, the risk of a febrile seizure with vaccination is lower, certainly, than with infection. And in particular with febrile seizures that occur after MMR vaccine, that shows a good immune response to the measles component of the vaccine in particular. And so that it means that with the next dose, they're very unlikely to have a recurrence because they were already, most of those kids will already be immune to the measles component, but like many of them may not be immune to all of the other components. In children with severe disorders, it is safe to continue with immunization and better to vaccinate them than to risk them getting the infection. And other severe neurologic events like severe paresthesias, transverse myelitis, we would, these patients, as well as those with Guillain-Barré Syndrome, should be referred for assessment of risks and benefits of further immunization. So in this particular case, it was really difficult to determine what role the vaccine might have played, if any. He never had a lumbar puncture or nerve conduction studies at the time of the event, and so we couldn't confirm the diagnosis. As well, there was this preceding otitis media that could have, this other infection that could have been a trigger for GBS. Fortunately, there was nothing in the literature to suggest an association with GBS in any of the vaccines he received for his 12-month vaccines. And so he was referred to our SIC, and we did plan to follow him up before his next dose to have another discussion around MMRV and further vaccinations. And he has since received MMRV and TNF-IPV without any issue, and was recommended to go on with the adolescent quadrivalent meningococcal vaccine when he gets to that stage. So finally, just to touch on the other systemic events, again, generally, we would recommend revaccination. So we know that the risk of recurrence of HHE, for example, is very low, about 2 to 3%. Persistent crying and fever do recur somewhat more often, but all of these can be managed with good pain control, antipyretics, and good and strategies to mitigate pain during the immunization event, like having the infant nurse or giving sucrose and using topical anesthetics to the vaccination sites. And then there's a couple other specific scenarios around thrombocytopenia and apnea where we would suggest that they should be referred for further assessment and more careful monitoring post-vaccination. So as I mentioned before, we've collated all of our guidelines into a resource for public health, which is available on the CERN website and is available as a downloadable PDF. And summarizes many of these AEFIs that I discussed today, as well as some other common AEFI types that you might encounter. It provides details not only of our data from the SIC, but also really excellent work that Jocelyn Zafak, who's now a PhD graduate, did with Gaston Dessel at INSPQ in Quebec City around AEFI recurrence in the Quebec passive surveillance system, as well as a systematic review. And so those form the basis for these recommendations. In addition to that resource, there's a couple other good ones I wanted to highlight. So for the healthcare providers, especially primary healthcare providers, there's a great CPS practice point that Noni McDonald and Barb Law wrote a few years ago, and that just summarizes the components of our vaccine safety surveillance system, and I think is really helpful when you're counseling families who are wondering how we know vaccines are safe and what are we doing about it. As well, the Canadian Immunization Guide, as many of you will know, has a section on vaccine safety, and these chapters are all in the process of being completely revised and updated. Some of the updates are already posted, and others will be posted in the coming weeks and months. So just to finish off, I know I've presented a lot of information. I think the basic take-home messages are that most of these patients who've had previous, mild to moderate adverse events following immunization that required medical attention can be revaccinated safely. They can be, reassured that the risk of recurrent AEFI is low, and that the vast majority of the time it'll be no worse than their previous AEFI. And certainly for those with severe allergic events and neurologic events, as well as other severe systemic events, the SIC network is available to provide support in evaluating and managing these patients. And we can also help point you to other specialists and resources to help guide management. So I'd like to acknowledge all those who contributed to the AEFI management resource, our site investigators, as well as our SIC nurses at each site, the allergists who work with us, and our data team at the Canadian Centre for Vaccinology here in Halifax. So with that, I will close, and I'm happy to take questions.
Well, thank you so much, Dr. Top, for your presentation. It was definitely very informative on AEFIs, and I really like the use of your case studies to help depict the types and severity and management of AEFIs. So thank you for that. For any attendees who have any questions, feel free to submit it in the Q&A box. I recently just, well, actually this is more of a comment than a question, but basically, thanks so much for your presentation. So interesting and informative.
Oh,
the comment
thanks
sent to
very
you.
much. Thank
you. All right, so we have another question that came in. How would a public health unit refer a client to the SIC in Ontario?
Great question. So probably the easiest, so it depends where you are. So we do have clinics at Sick Kids, at CHEO, and as well as Ottawa Hospital and at McMaster. So maybe I'll just go back a bit. Probably the easiest thing at the moment would be either to get in touch with myself or Natalie Georges, our project manager here in Halifax, who can direct you to the best clinic. But essentially, it's just a matter of sending a referral to your local special immunization clinic, and they would see it as a routine consult. And then we do encourage all of the investigators or the physicians to send back a copy of the consult letter to public health, so that even if I see patients that were referred from their GP, I'll still copy the local MOH to make sure that they know what our advice was, because they would probably be getting the AEFI report. And we encourage everyone who refers to our clinics to report those events to public health. We kind of make sure that happens. But I would suggest that you just contact Nellie Georges there or myself over email, and we can direct you where to go.
All right, great. Another question came in. For the two first cases, extensive limb swelling and possible anaphylaxis, IM influenza vaccine, would intranasal flu vaccine be recommended?
Yeah, so with the extensive limb swelling with flu vaccine, we have been recommending live attenuated flu vaccine, or the intranasal form. Unfortunately, it just wasn't available this year, so we didn't have that option. But that can be recommended certainly for children up to 18 years of age, although the evidence suggests that beyond 18 years of age, adults don't really respond to it, so there's less benefit, but at least, potentially you might give them a bit of a break. For the second case, in that case where we thought that it was syncope and a stress-related response, you certainly could go ahead and you could give intranasal flu vaccine the next time if that's something that may be less stress-inducing for the child. Although, children often don't really like having things squirted up their noses either. That's not very comfortable either, and you have to do it one on each side. So I think that would be kind of an individual patient decision. But in that case, if you did suspect an anaphylaxis or a type 1 allergic reaction, then you would want to rule that out before you would give any type of flu vaccine.
Oh, and just a clarification from the person who sent that, she meant stress response, not anaphylaxis.
Oh, okay, yeah. Yeah, so for stress response, again, you know, I'm not sure that the intranasal, I mean, it would probably be very patient or client dependent whether the intranasal was less stressful for them than the injection. But usually techniques like distraction and, you know, a quiet, calm, like setting can help with those types of events, as well as in some cases you may need to make sure that whoever's with the child, if it's a child, the parent is not themselves anxious, because the children will obviously pick up on that. So coaching the parents into how to properly reassure their child can also be helpful.
All right, great. So we have a couple more questions before it's 2 o'clock. So the next question is, since there is no SIC in Manitoba, what happens with the AEFI investigations beyond the MOH?
Yeah, so we're not actually involved with AEFI investigations. That would still be within public health. So Manitoba would be doing those. You know, so that would be that's really the domain of public health. If there's, I'm not sure exactly what happens there with patients who have adverse events that are more complicated. There are, you know, there are pediatric and adult infectious disease specialists who, you know, would be appropriate places to refer these types of patients, as well as allergists. They just haven't been hooked into our network and at the moment, but certainly we recommend, for if there isn't an SIC nearby, you can certainly refer to, you know, a pediatric or adult ID pediatrician or allergist, depending on the type of adverse event. And the resource that we've developed has some guidance on the appropriate specialists to refer to.
There was actually another follow-up question on that that I think you may have already answered, but it said, the attendee said, I noticed that Manitoba does not have a SIC location. Do you have a suggestion for consulting outside of the province? Can people consult / refer via a web consultant?
Yeah, so unfortunately we don't have like an official hotline or a web consultant at this point, but I think they could, you know, physicians there could contact, you know, any one of us in the network. If it's a patient that's near, you know, the Saskatchewan border, they could potentially go to Saskatoon if that was felt it would be helpful. But you know, I do also, in my role with Impact, also sit on BBWG and have presented this AEFI management resource there. And so if there is, you know, if there are specific questions, I'd be happy to help to field those and, you know, get input from the rest of the investigators and help figure out where is the best place for these patients to be seen.
All right, great. We just have 2 more questions before we end off. And for anybody else who does have any questions, you can also contact us on our CANVax page, and we'll direct you to Dr. Top. But just to finish off with these 2 questions. So one attendee said, I have had my son who has reoccurring redness, swelling, itchy type welt, like the 5-year-old after the flu vaccine. It never crosses joints or causes pain, but looks terrible for a week after. There has been a suggestion that using a longer needle, 1.5 inches, the next time he receives the flu vaccine. Do you have any info on whether that may be beneficial?
I don't have any evidence that would be helpful. I think it is just, it does sound like it's a, you know, reaction to the flu vaccine product itself, and not, you know, I guess it depends, not knowing how big he is. You know, you certainly want to have an appropriate length needle to make sure that it's not being given sub-Q, but if they're sure it's going into the muscle, we do see those types of reactions, as I was mentioning. And so, you know, I think you could try, you know, antihistamines like cetirizine, Reactine, something like that, to help with relieve the itching and swelling. But if it's fairly extensive like that, it's probably less likely to be, that it's not being administered properly. And I guess the concern with giving too long a needle would be that it would go too deep and could cause nerve damage or whatnot. So again, it would depend on how big he is, but if he's big muscly guy or has a lot of subcutaneous tissue, then a longer needle may be appropriate to make sure you get into the muscle. But as long as it's getting into the muscle, a longer needle is not going to be helpful. And so I think more just focusing on symptomatic management, and good for you for pursuing with the flu vaccine despite those nuisance reactions for sure, because that's not in for him as well. It's not easy, and unfortunately there isn't a whole lot we have to offer. I think one thought could be that the new cell-based vaccines, the flu cell vax, that's going to be licensed, or that is licensed now, or will be soon, I think, may be an option for next year, and it's made a bit differently, and maybe that might help relieve it, so, or prevent, may cause fewer reactions, but that's not based on evidence. That would be just something that could be something to consider trying.
All right, and so for our final question, for health unit referrals, does the referral need to come from a physician, or can a public health nurse also send a designate for the MOH or AMOH?
Yeah, so we're fine with the public health nurse sending a referral on behalf of the MOH as a designate. The only thing that we've run into here in Halifax is that we do need a physician on a physician's name to actually submit for billing, so to our provincial health insurance. So if the MOH designates the public health nurse to send in the referral and attach their name, then that should be sufficient. Yeah.
All right, so that concludes the end of our webinar. So thank you all for attending, and thank you so much, Dr. Chop, for presenting your webinar. As a reminder, please don't forget to fill out the survey and provide your feedback. This survey will be made available to you upon the closing of the webinar window. And once again, if you do have any questions for Dr. Top after the webinar, feel free to just contact us, CANVax, via our contact page, which you can find on our website. Also, as a reminder, some of the resources that Dr. Top mentioned in her webinar are also available on canvax.ca, so you can find them there. But for now, thank you all and have a wonderful afternoon. And thank you, Karina, again, for that amazing presentation.
Yeah, thank you.
Great.